Hello everyone, my name is Lou Zacharilla. I'm a founder of the Intelligent Community Forum, and welcome to this episode of our No Place But Home series on the COVID-19 crisis. We are recording from New York City. Today is April 30th, 2020. It has been 49 days since the World Health Organization declared this a global pandemic. There have been 61,361 deaths in the United States as of 9:15 Eastern Time last night. In New York State, where I am, where the first case of COVID was reported on February 29th, there were 330 deaths as of Tuesday evening, according to our governor, Andrew Cuomo. Many of you may have seen on your televisions or online to cheer our healthcare workers here. The Blue Angels did a flyover of New York City on Sunday, and at 7 p.m. New Yorkers continue to go out into their balconies by the thousands, open their windows, or literally go to the front of their buildings and cheer the healthcare workers. It really does remain a remarkable moment in the city. Even dogs bark all around the city. Also in New York State, the state government redirected its commercial contracts that it had with schools and dairy farmers, those who provide milk, of course, to our thousands of schools here, to food banks. And this prevented the state's dairy farmers from dumping it. As to whether this might be an innovation that might evolve from this crisis to help us with food insecurity, which appears to be on the rise, is probably a good question for today's guest, Ms. Pat Schou. We're delighted that she's here with us. Pat is the president of the National Rural Health Association in the United States, as well as the executive director of the Illinois Critical Access Hospital, the first statewide critical access network established, which consists of 57 critical access and rural hospitals. In addition, she is also the executive director of the Illinois Rural Community Care Organization, and it's a statewide rural accountable care organization comprised of, I believe, 27 critical access and rural hospitals. So obviously a very, very important function, as the trend has been to have fewer rural hospitals over the last 15 years or so. Pat has more than 40 years of clinical and rural hospital administrative experience. She was awarded the Calico Rural Leadership Award by the National Rural Research Center, Rural Hero Award by the University of Illinois, Rural Medical Education Group in 2016, and received a Community Hero Award from the Meridian Health organization last year. She is a fellow member of the American College of Healthcare Executives, as well as a speaker nationally. I don't know where she found the time to be here today, but we're glad that she did. Pat Schou, welcome to No Place But Home.
Thank you very much, Lou, for the wonderful invitation, and I appreciate being able to spend a few minutes with you and talking more about rural health care and opportunities for us in the future.
Well, we look forward to that discussion. And just to get our bearings, where are you physically today, and what's the situation in your hometown?
Okay, I'm located in Princeton, Illinois, which is a rural community, about 8,000, and that's located in a rural county, Bureau County in Illinois, and that's also agricultural rural-based county. We're about 2 hours southwest of Chicago, and I'm in our corporate office. If you want to be rural, I think you have to be rural, and I'm like you, I'm from a rural community, grew up on a farm, and so I'm very passionate about rural health care and the importance that it plays in the success and the viability of rural communities.
Absolutely, and you'd mentioned that I was born in a small town in upstate New York, and proud of it, and still spend a lot of time back home. It always feels like home. Pat, what is the role of the National Rural Health Association here in the United States? Because we have, of course, many domestic cities and communities that listen to us, but also internationally we have a pretty wide audience, and some of them may not have heard of this. Can you just give us an overview of what that is?
Yes. National Rural Health Association was established in the early 80s as a way of bringing a voice to people involved in rural health care, from universities to physicians to nurses to hospitals, clinics, community health centers, a variety of organizations that really are dedicated to rural healthcare. And it's evolved over the last 40 some years and really has become a prominent voice as you look at new legislation, as you look at changes in rural healthcare. People often look to the rural healthcare organization for its leadership, its comments, its education and resources. And the office itself is actually located in Washington, D.C. Alan Morgan is its executive director. They also have an office in Kansas City. NRHA has evolved, as I said, over the last number of years. Last year, actually, it partnered with WONCA, which is the World Organization for Academics and in colleges, national colleges and academics, and they partnered and hosted a rural, national rural organization conference in New Mexico. And so we've been actually reaching out to countries across the world, and they like a lot of the work NRHA does. We have research, we have a national fellowship program, which helps new executives evolve and learn more about rural healthcare. So it's become a prominent figure worldly because of the work that we do nationally.
Very good. I was going to ask you that because the international component of the COVID spread seems to be something that lends itself to having organizations like yours collaborate further internationally. It seems like one of the fault lines seems to be that we have isolated responses to this. And with regard to healthcare, people are talking about a more coordinated response for the future. Do you agree that that would be a good direction to go? And do you ask communities to be more involved with you if that's the case?
Yes, I agree totally. And we haven't had a lot of involvement internationally during this crisis because I think we've worked very hard to coordinate activities, responses, strategies, concerns, internally within our country, with a number of the health providers, making sure they have the information. As you've been reading, there's just one new regulation, one new funding program almost every day. And so it's impossible to keep up. And so the National Health Association has paid a lot of attention to providing that information and keeping information flowing. Just as my organization within Illinois has had to do the same, it's just keeping everybody abreast. We have not had a lot of international focus, but I suspect after the pandemic has waned, we'll be able to share our experiences with other rural countries and also share our experiences locally, so we can learn from it and be better prepared and move ahead with our business plans in the future.
Yeah, and you must have accumulated a lot of best practices over the years that can be shared. Rural healthcare does seem to be a fragile part of our human infrastructure, and I actually can wake up in the middle of the night worrying about my hometown not being able to handle an outbreak of COVID, whether it's on the farms or in the community itself. Pat, are you seeing specific fault lines that occurred even more prominently during the time of COVID? And where would you see the most need is for help and support among the rural communities?
Sure. Early on when the COVID hit, particularly New York and other places, there were hot spots in our rural communities in Indiana, a place in Connecticut, a place in Montana. For some reason, those were places close to an urban area or a transportation center, and they really hit these small rural hospitals. And they had an overflow, just like New York and California and Washington State initially, but they responded well. We appreciated the Centers for Medicare and Medicaid. They opened up a lot of regulations so organizations could expand their numbers, like critical access small rural hospitals. We only have 25 beds, but we're basically an outpatient organization. But in the crisis situation, we were allowed to expand and have flexibility in how we manage patients. But generally, our rural communities have not been hit as heavy other than those few hotspots. We've had COVID cases, but they've been able to be treated at home. A few have been hospitalized, but not where we've had to place them on ventilators and so forth. And I think as we progressed with the time frame, the impact of COVID has not been as great. You know, early on, I think people didn't know quite what to expect, especially in our rural communities. But now we understand it, and we've been able to prepare for it. Our hospitals, you mentioned, you know, you worried about your local hospitals, but they've been working over years preparing for it. Yes, we didn't quite know how many supplies of gowns and masks and things we were going to need, but they've had those in place and have been prepared for it. The challenges is being ready and yet wondering who's going to walk through the door. They've set up tents, and they set up other areas in the within the community so that they can do triage to protect patients. So it's felt a safe environment, and we've been very pleased with the response and how they've been able to contain. And I will say we've had some deaths in our small rural communities, and but they've been more people that have had advanced directives. They might have been in a nursing home or been in their own home and developed an illness and developed COVID, and they simply just passed. And so that was a good thing that, you know, we were able to work with these people through hospice and other kinds of programs and have a good resounding for that. But for the most part, we've been prepared for it. There are challenges because of testing, no different than in the hotspots, urban areas. And the problem with our rural communities, sometimes we're the bottom end of the chain. You know, if you're a small rural community hospital, you may not be able to get your testing material. We can do all sorts of testing, but many of our rural hospitals have the actual equipment that they can do the testing locally, but we can't get the materials, the reagents from the companies. They're all going to the hotspots, and we just can't seem to get them. So that's the problem of being small rural. You're the last person sometimes, but I don't want anybody to be afraid to not come into our small hospitals, because they are prepared. They've segregated areas for people to come in and so forth. And I wanted to be assured that we're very capable of taking care of people.
Well, that's comforting to hear. And I suspect a lot of the challenges is also the ones we experience, which is supply chains and so forth, which states and you know, municipalities really can't do. That's a federal function. But you know, in a recent interview with C-SPAN, in which you were terrific, by the way, you mentioned the number of rural hospitals that have been downgraded, and I think it was, I'm looking at the number here, 170 hospitals in the rural sector have downgraded since 2005. And so the question that I wrote down when I said I'm going to talk to Pat about this, what has picked up the slack? Because, you know, we've been doing interviews around the world, and in Taiwan and China and those places, governmentally, the cities actually look after their rural areas. There's funding for them. They almost operate as one entity. Do we have anything like that, or is there a function like that? And so the question is, what has picked up the slack from those rural hospitals? Because we lost 2 in my hometown. The hospital I was born in is no longer in existence.
Yes. Well, it is really difficult for a community to lose their hospital. I won't say that isn't a concern, because, you know, economically it's a wonderful economic engine, because, you know, it's a source of healthcare, and people come in and out of the community, and the ambulance services and all those sorts of necessary services that are important for our community. The issue is since 2005, and it really ramped up more in 2010 with the changes with the Affordable Care Act. Not that really aggravated it, but I think we paid more attention to it because we started looking at value-based care and so forth. But we've had actually 128 since 2010, and 10 this year so far. And part of it has to do with reimbursement. It has to do with geographics. Maybe people there's not as many people there, the volume goes down. So what happens when a hospital closes? Sometimes you're able to put a clinic in. Sometimes you can build a partnership with a larger facility, and they can bring specialists in, but you never ever replace that hospital that was once there.
That's true. But as we were talking about earlier, and anybody who knows the Intelligent Community Forum knows that we say that the rural communities, you know, can become very, very strong again, and are beginning to, because we have a technology called broadband that is providing services like telemedicine, that is allowing people like myself to maybe go back home and stay there and do my work. that seems to us to be something that is very, very significant. How are you looking at broadband and telemedicine models? Can you just talk to that a little bit? Because I know it's important to the rural communities.
Sure. Broadband really will open the doors for our rural communities. And with the COVID, we've been able to adjust some of the regulations where our hospitals can do actually visits through their clinics and practices with people in their homes. And that's been something we've not done in the past, and that allows people to be seen. And that really is going to open the doors for our rural community hospitals to maybe network closer with their nursing homes, with other areas, that we will just be as close as walking through the door. And it allows people like yourself, you could live almost anywhere because you have technology. We hope you choose to live in our rural communities because we have wonderful schools and programs, but it's important that you still maintain the basis of rural healthcare, because we've been able to do that, and that's kept our country strong because food costs are lower than in many countries. We have all our natural resources, they're obtained in our rural communities. So we have to have that rural infrastructure to preserve those things. And so if we can't have a building, then let's have a way that we can connect with providers to bring that locally to our communities. And so broadband is going to be very important. If you look at the numbers, rural still lags behind urban in capabilities with broadband, probably about 15% difference. About 3/4 of the country is covered in urban with broadband, and rural lags behind about 68%.
I mentioned to you also that I have a good relationship with the satellite industry, having started a business in it. Are you looking at other options? It's a twofold question, really, Pat. Are you looking at satellite as we start to introduce new technologies like low Earth orbit satellite, high throughput satellite, that kind of stuff? And do the rural communities still find the big challenge to be funding the broadband networks and stuff?
Yes, it's accessibility to the satellite services and accessibility to funding, because like I said, they're still lagging behind, and we need the states to make sure that all the areas within the state are covered. And that's really going to help our rural communities, because then we can extend to those areas. If people can't travel, then we can reach out to them. Now, the other problem that remains is, does everybody have a computer? Or do they have a laptop type or iPad solution, and if so, can they use that? And, in our rural communities, we have more elderly population, and some of them aren't as comfortable with technology. Are we bringing them kicking and screaming to the 21st century, so to speak? But we have to get our technology up to speed, and we need to have train our rural people to help those others that aren't used to technology learn about it. And the problem with the COVID virus is that your libraries are closed, your schools are closed, where those are other access points that people can use in a rural community if they don't have it. I don't know if you remember on the C-SPAN program, I talked about how some rural community people have gone to McDonald's that drive around their parking lots or other areas which might have internet service just to get that, because they don't have it locally. They don't have a hotspot or a cell tower. Most people have a cell phone, smartphone now, but it's the internet service and the capabilities of doing it. So in our rural communities, as we look forward to the future, we have to think, how are we going to incorporate telehealth technology into it? And we have to be able to do it on a long-standing basis. We can't start and stop. We have to learn how to use our apps. Can we help people with chronic diseases with our applications, that they can use in a smartphone, or a neighbor can come and check on them or call them. I mean, we have to really get creative with that. And it's going to take us some time. We're going to have to learn how to do it well. All of a sudden we've got technology thrust on us, but are we good at interviewing people? Are we good at recording information? Can we use the technology? It's been around for years that you can use a stethoscope and hear hearts and hear the heart and listen to the lungs and all that. But have we really used it well? Have we evaluated ourselves? And so there's a whole stream of work that we need to do once we relax from the COVID virus and start thinking about our business and how we're going to keep our populations, our rural populations, safe and strong.
Yeah. And you were also suggesting in that interview that there, and we know this, that there are a lot of ideas that have been floating out there or models that have been tried for, 10, 15 years in this area. Places like Mitchell, South Dakota do very, very well. The Avera healthcare, I mean, it's the model. And they've restored that loss of population that they had back in the 50s and 60s, and they're thriving now. They lost 30% of their population. It's all back now, and they do real well. So we know it can work. To your point about people being taken care of, because I think loneliness and isolation is a big issue in those places. We saw in Eindhoven, in Holland, many years ago, a public housing system where people continued to live in the community, but they were monitored by nurses on a continuous basis, and they developed relationships and friendships, and it kept them out of institutions and nursing homes. So, I'm sure the work that you've looked at has all these different models. Maybe this is the time to start to pull them together, with COVID being sort of the trigger or the initiator. The other thing I wanted to mention, Pat, was, do you think this is a time of opportunity for the rural communities to begin to sort of promote themselves as a very, very attractive option? And the reason I ask that is because we had a long discussion yesterday with a group of urban designers and planners from cities, Toronto and New York and so forth, San Francisco. And one of the topics was fear of density. The density all of a sudden, which, in New York here is an asset, or we've always seen it as such, may become something that people are a little skeptical of. Do you see that trend evolving, and do you see it as an opportunity for rural communities going forward?
Yes, I do very much. I think this opened the door for us. I mean, in the fact that, we have wonderful schools, and if we work hard to keep our rural healthcare system in place, that'll be very important. But, you don't have to live in downtown Chicago to have internet access, as we talked about, as long as we can roll that out to everybody. And people are becoming more, FaceTime. I FaceTime with I have a son that lives in the country of Cyprus, and he works for the medical school. And we FaceTime, 2 or 3 times a week. And so, you don't have to live in the cities to do that. You can be in your country, and you can go for a walk. I mean, the thing is, you also look at the economics. How much does a house cost in Princeton, Illinois, compared to how much a house costs downtown Manhattan?
Oh, don't even ask.
Or LA. So, you can come and have a lovely home. You can have a backyard. You can have neighbors, and you can talk to your parents that live somewhere else on the phone, and you can FaceTime, and you can work from your home. You can set up your office so that you can, you can do your computers and so forth. So it's a great opportunity, but we also have to have a responsibility on rural communities to cultivate it. We have to make it easy for people. We have to give people some directions and make it open for them to do that. And so we have a little work ahead of us, but the opportunity is there if we take advantage of it. But we also have to do our fair share in making it easy and showing how people can adapt and learn and be that open arm for somebody coming in. Maybe not necessarily that handshake, but that arm bump,
Fist bump,
so that people feel welcome. And I think that's what people like about rural communities. That's what they like about our rural hospitals, is that they know those people. They know that doctor, they know that nurse. We're very confidential with information, but they know that and they trust them. And that's very important, to know somebody that is your neighbor is going to take care of you when you're sick. That's
Absolutely.
really a wonderful feeling.
Yeah, it is the 3-dimensional human response, right? It brings the emotional component into it. You're absolutely right. But digital literacy is going to be important to those populations that stay there. We don't want the best and the brightest leaving communities. We want the brain gain, not the drain coming. And it's funny, I remember my mom, the way she achieved digital literacy was when we started asking her for her pasta recipe. All of a sudden, she got really good texting us and going online to send her recipes. So there's always a motivating factor there, right?
Right. That's right. That's right. And it's exciting. And I have to say, in the Princeton community, we've had a number of the individuals that were in the, I think they're in their early 40s, have come back to Princeton. A number of the kids that grew up in Princeton are now coming back because they want to build their homes here with their families. They want to build small stores downtown, because they can, if they want to get something, they can go online to Amazon or whoever and get what they need. But you know, they want to have a local shop, or they want to go to the barber shop, they want to go to the local pub, and they want to have their kids have a place to play and grow up. So I really think this is a wonderful opportunity for the resurgence of the rural community.
I do too. And obviously we're going to make work to make it so. But you know, the determiner that we hear when we go out and we talk to people is healthcare. There still is a lingering concern that people, you know, who are near retirement age or in their 40s and 50s and want that quality of life, that they may not get the healthcare yet. What would you say to that concern?
I would disagree with them that I believe our rural healthcare is in good order. You know, our small hospitals, even though they're small, they all have physicians in-house. These are emergency trained physicians to take care of your emergency. We have practitioners, we have physicians, and they're located in primary care. That's what rural communities do best, is primary emergency care. We're your access point. We can connect with each other. We talk with each other. And I think you can be reassured of that. We work with our long-term care, our home health services. Yes, we might not have the endocrinologist sitting right next door to take care of every issue. Now, however, some communities do have endocrinologists, but we may not have every specialty there, but we have primary care, and most of your health care is 80 to 85% is primary emergency based. Yes. And that's what we're set up for, and not to be worried about that. We all go to the same medical schools or nursing schools or mental health and behavioral health. I mean, we have, with technology, just talked about, digital and telehealth. Well, mental health services, so many of our communities have mental health services. Even our geriatrics, our elderly population, they have group programs, geriatric site. They meet either individually or as groups, and it's a wonderful service. So you don't have to worry about that.
Yeah, and
we'll take good care of you.
Oh, good. And as you said earlier, when you meet specialists, as we noted I mentioned Mitchell, South Dakota, there's a terrific telemedicine program that will bring in specialists from around South Dakota, around the country. So that capability, which didn't exist before, now exists. So that supplements the primary care that you referred to. Final question, Pat, and then I'm going to let you go back to work. But I wanted to throw this in because it was that issue of the dairy farmers in New York State. I don't think people realize how big our dairy farming industry here is in New York State. We're one of the largest in the country. It's not just New York City. We've got 2 mountain ranges, 8 Finger Lakes, right? A lot of farming. And we're providing milk to the schools, which are now closed. Governor Cuomo said, hey, wait, we're going to have to redirect these contracts because we've got food banks, we've got other needs in our community. So the state will step in and I think assume those contracts so that the milk doesn't go to waste. Another sort of innovation question for you. Are you seeing any models that have evolved from COVID where the producers, where the farmers have found other markets or other venues to markets in the last 8 weeks or so?
Well, not necessarily locally here within Illinois or my community, but historically, we have the sharing of vegetables and products in our local markets in our communities, and I think you'll see more of that. I know in Illinois we have a number of meat packing plants, and we're watching those very carefully to make sure that the meat gets distributed. And if not, I think they're making them available to food banks and so forth like that. I know there's been restaurants that have had oversupply. They don't have, early on, they had extra inventory. And so they gave them to food banks. They called up seniors and they distributed a lot of that way through kind of the Angels on the Porch program where, they had excess inventory supplies. They took took them out to that, but not as aggressively as Governor Cuomo has with the milk industry in New York. I see that model probably rolling out to others. We're not such of a big dairy industry in Illinois, but I know, in Iowa, in Wisconsin, and other areas like that, and it certainly makes good sense. We do a lot of work, I'm talking about our rural communities, with food that goes home on the weekends with families, and that's what's not happening. And you're seeing other ways that churches are distributing food packages to families that don't have the resources that they need to feed their families.
Yeah.
So they're using it that way.
Good. And I think that's a good short-term solution, but I think long-term, we're going to be looking at things more structurally so that we actually can decrease food insecurity and not have to make it something that's special, but it's part of this amazing productivity we have on American farms and rural communities.
And it's interesting, we don't have the local grocery stores that we used to have. Everything's gone to bigger stores, and it's nothing wrong with the Casey stores or the gas station that carries milk and bread. That's all wonderful, but you still need your fruits and vegetables and canned goods and things like that. So we're going to have to figure out how we can be more creative and not have those food deserts, whether it's in the urban areas or in our rural areas, as we rebuild and rethink. So people coming to settle in our rural communities, the more population, the more adaptability that we're going to have is the return of the more grocery stores and access to food sources.
Yeah, and you've begun to see this in places like Walla Walla, Washington, and so forth. More wineries, more food people coming in, taking advantage of all that beautiful local crop, and we're getting there, I think. Anyway, Pat, I really want to thank you for making the time to be with us today. It's just been an honor to speak with you. And
I appreciate the opportunity and to share more information about rural healthcare and encourage people that our rural communities are strong and vibrant. And we're looking for our next person to come and bring us a new idea and give us support. So we think our future is in rural. Thank you.
Listen, you invite me out there, I'll be there.
All right.
And you can learn more about the National Rural Health Resource Center at ruralcenter.org. And the No Place But Home series is produced by ICF as a service to its network of cities and communities, intelligent communities around the world. Shout out to our series producer, Matt Owen. And please join us next week for another conversation. We also hope you can join us in Dublin, Ohio from October 21st through the 23rd when we bring together the world's leading intelligent communities and people like Pat for our annual summit to think through more of these issues. To see prior conversations and to read my weekly blogs, which report on my experience here in New York during the COVID-19 crisis, go to intelligentcommunity.org/COVID-19. And you can follow us on Twitter at New Communities and on Facebook. For the Intelligent Community Forum and our communities and your community worldwide, I'm Lou Zacharilla, reminding you that there really is no place like home.